Okay, so let's kick off. So this evening we're going to speak about the safe mechanical preparation of the endodontic space. And in particular, we're going to describe the preparation of the canals with the high-flex EDM system. And we know that the aim of endodontic treatment is to prevent or heal apical periodontitis. So no matter how good looking your endo is, if you do not get the bacteria below a certain subcritical threshold, the apical disease is going to persist. For example, with this retreatment, a year later, you see complete healing of this area. So what gives us this kind of success? So this kind of success is achieved by thorough disinfection of the space, and we need to prevent the reinfection of this endodontic space. And I have in the recent past discussed both of these. One was a lecture on irrigation, and for those that missed it, you can catch it on YouTube. You just type in contemporary endodontic irrigation, and then the more recent one was the obturation lecture, but it was a bit more than obturation. It was on bioceramics and bioceramic obturation in particular. So the function of instrumentation is to create a space. And the reason that we want to create the space is to irrigate and obturate. Now, in my view, the irrigation and the obturation, these are the two easy parts. It's actually the creation of this space within the canal, or adequate space within the canal, that makes our life really, really difficult. So we're going to speak about root canal preparation, but before we get to, and I speak solely from my own experience, before I get to lift up a file and do any root canal preparation, there are 6 key things that I have to accomplish before engaging the canal. And one is an accurate radiological diagnosis. 2 is rubber dam isolation. 3 is my pre-endo build-up. 4 is magnification. 5 is access cavity preparation, and 6 is orifice location. Once I've accomplished these 6, I can start my preparation of the canal. So we're just going to touch a little bit on these 6 factors before we start talking about instruments and preparation. And I like to call this part of the presentation my journey to the orifice. So first is the accurate radiological diagnosis. I'm not speaking about the pulpal and periapical diagnosis. It's the actual anatomical diagnosis of the canal. And the best way to do that is by taking a preoperative CBCT. And I'm fortunate at present that we have a CBCT machine in our practice. And I take a CBCT before almost every case. And it helps me, it guides me. It'll tell me whether there's an MB2 present or not in this upper molar. If we have a C-shaped configuration, I know exactly that in the mesial root, I've got to look for a deep split buccally and lingually. It tells me whether a resorption is external or whether the resorption is internal, so I know how to manage it. And the second factor is rubber dam isolation, and this song has been repeatedly sung. I think if there's ever one good thing that came out of our COVID experience is that a lot more dentists started using rubber dam, and that's a fantastic hygienic practice. I mean, with one clamp and this piece of latex or non-latex, it be able to retract all the soft tissues and create a sterile working field. It also removes background visual noise, so we can zoom in and create good visual access to a particular area only. And most importantly, we can apply tactile sensation to our instruments. We can apply those feather-like touches to the instruments. Now, if we are not using rubber dam, then we cannot handle the instrument delicately because we are more concerned about the instrument being lost and slipping down the patient's throat. And if that happens, we know it's either an aspiration or an ingestion, and this is something that we want to avoid at all costs. So rubber dam is a must. The third is the pre-endo build-up. Before we enter the tooth, we need to fix the house up a little bit. I mean, there's no way I would just initiate an endodontic treatment on a tooth like this. I'd want to clean out all the caries. If the pulp is exposed, block it out with Teflon and build up a nice composite initially. And the reason for that is that we create four walls for a reservoir for our irrigant. And also, we don't get bacterial contamination of the canals between appointments, during the appointment, and no leakage of the irrigants. The fourth factor is the use of the operating microscope or loops, so some form of magnification. I didn't have too much of experience with loops. I went straight to a microscope and I haven't looked back. And you can see this pose of mine was before COVID time when we weren't so afraid of picking up the virus from anybody. So I was able to just pose there with my mask down. The fifth factor is our access cavity preparation. So we were used to our traditional wide access cavity preparation, straight line access, and it's still debatable. The literature is still debating whether there's how much of benefit there is to the conservative access or not. But at the end of the day, the less dentine that we remove, the greater the fracture resistance of the tooth is. So in this recent study, the access cavities were classified according to the amount of dentine that was removed. And it's found that in the traditional or standard access cavity, more than 15% of enamel and dentine was removed. The conservative access cavity, 15% or less, and the ultra conservative was less than 6%. That's your ninja access. And the whole idea of creating a more conservative access cavity is to protect the pericervical dentine. So this is the dentine that's found 4 millimeters above and below our crestal bone. And the more pericervical dentine we have, the longer the tooth will last. But I feel that one should just be practical about it. I don't think that there's any benefit in creating a very conservative endodontic access cavity and not locating your canals or not being able to effectively carry out the endodontic procedure. In other words, we don't want to make an already difficult procedure even more difficult, and that's my philosophy on it. So just remove as much tissue as is required. So orifice location. This was an excellent 2004 study by Krasner and Ranko on the anatomy of the pulp chamber floor. And what they did was they took about 500 and somewhat teeth, molded teeth, and they studied the pulp chamber floors. And from this, they found consistencies. And from those consistencies, they were able to, consistent landmarks, they were able to formulate laws such as the law of centrality, concentricity, symmetry, color change, and orifice location. So it's not within the scope of this presentation to go into detail in this, but if I can just give you a few pointers and refer you to this article, it's easily located via Google. So the law of centrality states that the floor of the pulp chamber is always located at the center of the tooth at the level of the CEJ. So what that means for us is that if we drill in the absolute center of the tooth and not past the CEJ, we're not going to perforate. And there's a law of color change where the pulp chamber floor is always darker than the walls. So we got dark floor, light walls, and that helps us to distinguish. Also, the law of orifice location. The orifices are located at the angles of the floor wall junction. And the orifices are located at the end of the root developmental fusion lines. And this is our so-called road map of the floor of the pulp chamber. And there's laws of symmetry when it comes to the lower molars. I don't want to go into too much detail there. But before we even get to exercise these laws, we are faced with pulp stones and obstructions in the canal, and we need to use ultrasonics to remove them. For example, this case here with a pulp stone, I like to flood the pulp chamber with sodium hypochlorite and try and break away at that pulp stone. And if you look at this case, you'll see I've got the pulp stone a bit loosish, cut around it, and flick it out. So the seventh way we get to is root canal preparation, and this is where absolute caution has to be exercised. So for a long time, all we had were stainless steel hand files to carry out this procedure. Then nickel titanium was developed in 1959 by the US Navy, where they were looking for an appropriate metal for the nuclear missiles, for the nose cone of the nuclear missiles. And they developed nitinol, and it got introduced into orthodontics in 1971. And by 1991, the first NiTi rotary instrument was developed for commercial use. And the advantage that nickel titanium has over our stainless steel instrument is that we can apply a lot more stress to it than the stainless steel instrument before it fractures. The stainless steel instrument reaches its elastic limit and its plastic limit far quicker than our stainless steel, than our nickel titanium instrument. And we all know, well, most of us know what this feels like. It's a horrible feeling when that occurs. And apart from the feeling, I mean, this could cost the patient the tooth if we are unable to remove the instrument. So, and the reason that we have the reason that we have this flexibility of the nickel titanium instrument is because it has a property called superelasticity, and this allows us to negotiate curvatures that we couldn't easily do before with a stainless steel instrument. Now, since 1991 and now, there are over 160 rotary nickel titanium instruments available worldwide. There are now 5 generations of them, and I don't want to go into details of each one. I can tell you my journey over the past 2 decades. I started off with the Hero 642 by Micromega, and I was on the Hero 642 for quite a while, for about, I would say, for about 9 years. And then I moved to ProTaper Universal. And after ProTaper Universal, I moved to ProTaper Next. I didn't really like it. I moved back to ProTaper. And then when Wave 1 came out, I moved to Wave 1. When Wave 1 Gold came out, I moved to Wave 1 Gold. And then this is now the 4th year running, I'm using HiFlex EDM files, and I haven't looked back. So let me try and describe to you what makes these files so special to me. All these instruments, these nickel titanium instruments, have a property called shape memory. And to explain to you what shape memory means, nickel titanium exists in two states, 2 atomic states. The first one is the austenitic phase or your austeni phase, and the second is your martensitic phase. And your austenitic phase is the parent compound, and this is hard and non-elastic. And your martensitic phase is the soft, flexible phase of nickel titanium. So how do I move nickel titanium from the austenitic phase to the martensitic phase, and from the martensitic back to the austenitic? There are 2 ways essentially, and the first is temperature, and the second is stress. So let's look at temperature. Once we cool nickel titanium, the rigid nickel titanium, it becomes soft and flexible, and it moves into the martensitic phase. And then as the temperature heats up, again, it goes back into the austenitic phase. And to demonstrate this, I think this was something I found in my drawer. I think it was an old X3 file. It's something that I don't use anymore. So you can try this in your practice. Just apply your endo ice, ethyl chloride to it, and it makes it soft and flexible. And as it reaches ambient temperature, it becomes rigid and austenitic again. So the other way, and this is more applicable to us as clinicians, is the stress-induced martensitic phase. So what creates that stress is the canal. It's actually the curvature of the canal. So when you introduce the instrument into the canal, the bend itself will turn it into the martensitic phase. But it's important to remember in these shape memory files, when the instrument is past a bend like this, because it has shape memory, it is constantly trying to restore itself. It wants to straighten up again. If you have an austenitic file or shape memory file, when it's in the austenitic phase, we apply our load on it, and then it turns into our stress-induced martensitic phase. As soon as the load is taken out, it goes back to its austenitic phase. And the hazard of it is one hazard, possible hazard, is transportation, because transportation is described as the removal of the canal wall structure in the apical half due to the tendency of the file to restore themselves to their original shape. So if it's run for too long in a certain area, it can cause a ledge or apical transportation or perforation. And the other hazard is file fracture. This was a case that I did a long time ago. It was a shape memory file that broke around a severe curvature, and I was fortunate that I was able to work my way out of this one by bypassing. So let's understand a bit about fractures. There are two reasons that an instrument fractures, and the one instrument is called torsional stress. So torsional stress means that the instrument binds, the tip of the instrument binds, and you see in this video, this instrument is being forced past the apex. So it's forced past the apex, encouraging the tip to bind, and when the tip binds, you'll see the tips, it stops moving, and the rest of the instrument is still moving. Yeah, that's called failure due to torsional stress. And this is a classic example of an instrument that fractured due to torsional stress. And it also highlights the need to get a proper apex locator reading before introducing a rotary instrument, so that it doesn't bind at the apex. I see a lot of instruments that are bound at apex, and most of the time it's because an accurate apex locator reading hasn't been achieved. The other reason is cyclic fatigue. So cyclic fatigue is when it's going around a sharp curvature, and as it's going around that sharp curvature, on the inner curvature we get a compressive stress, on the outer curvature we get a tensile stress, and this combination of tensile stress and compressive stress can result in file fracture. And this is how cyclic fatigue is actually measured in the studies. The number of cycles to fracture are measured. So so most of these 5th generation of instruments have what we call shape memory. But in 2011, HiFlex CM was developed, and the CM stands for something called control memory. So this was a new development, and I'd like to share with you the benefits of this. So if we just remind ourselves, shape memory is where you apply a load, and once you take the load off, it springs back. But with control memory, you apply a load, and once you remove that force, the file does not bounce back. So there's no bounce back. It stays in a martensitic, and that's because it's a martensitic file, and it stays in a martensitic phase at room temperature and oral temperature. So the austenitic martensitic transition phase is 52 degrees Celsius. So if the instrument goes above 52 degrees Celsius, it turns into its rigid austenitic phase, and as long as it's less than 52 degrees Celsius, it will be in a flexible martensitic state. And that's a great advantage, because when this instrument is traveling around a curvature, it is not trying to restore itself, and it is basically relaxed around the bends. So the benefits, we say, are superior canal tracking, high cyclic fatigue resistance, and we're going to look at numerous studies to prove that, and regenerative properties. So we're also able to pre-bend the instrument, and I've got a video showing us that benefit when it comes to locating orifices that are difficult to access. And also it rotates passively around the inner curvature, so it's able to stay centered in the instrument because it's not constantly trying to restore itself. And it has outstanding fatigue, cyclic fatigue resistance. It was found to be 300% higher cyclic fatigue resistant than the current files at the time. Remember, this was about a decade ago, so it was measured against the files of its time. Here it was measured against M-wire, and is found to have, this was the original HiFlex CM. It was found to have a high cyclic fatigue. In this study, Professor Hapatsalo and colleagues, they measured it from an endodontic graduate program, 468 HiFlex CM instruments. And what they found were, and this was after using it in 3 teeth, there were no fractures, and only 16 of those instruments revealed any deformation. And the third advantage here are the regenerative properties. So regenerative properties, when it undergoes strain, it tends to, the spirals tend to straighten out. And after putting it back in the autoclave, it reverts to its original shape. And the studies prove this. This study proved that the HiFlex CM instruments, after coming out of the autoclave, 79% of them were able to regain their shape. And as of 2016, Coltine has developed the HiFlex EDM file. And what makes the HiFlex EDM file so special is that the HiFlex CM is created or developed via grinding or milling technique. With HiFlex EDM, it is made by a process called electric discharge machining or spark erosion. So it's actually cut by a spark, where your workpiece is your control memory wire, and your cutting tool is your electric spark. And so what does this do? This creates a very hard surface, and so that improves the fracture resistance, and also creates a serrated surface, so it improves your cutting efficiency as well. And I'm going to give you a brief introduction to the instruments. Dr. Sibui is going to discuss with you the actual technique for using this, because they were not used. They're not used in the conventional way that most of us are used to with other rotary instruments. So we have 2 glide path files, a 3%, which is my favorite file. Initially, they came out with a 1005, a 10 file with a 5% taper, and Dr. Sibui will explain to you the reason that if we're using the 1005, we have to use the 1503 first. Most of the time, I get away with using only the 1503. It's only in severe curvatures that I'll go 1503 and 1005. There's a specific reason for that, and I'll let Isaac explain that. The next is the 2005 preparation file. This is an excellent instrument, and it goes very comfortably to apex after a good glide path is achieved. And then the HiFlex 1 file, which is a 25 at apex. And these files are run at 400 to 500 RPM. I use them at 500 RPM, except for the glide path file, which is run at 300 RPM. So the interesting thing about the HiFlex 1 file is that it doesn't have a constant taper. It has an 8% taper from the apex up to 5 millimeters, and then it switches to a 4%. So it gets narrower as it goes up coronally. And it has 3 cross sections. It's rectangular at the tip, trapezoidal in the middle, and near the handle, it's triangular to give you more flexibility. So let's look at this video about demonstrating its martensitic properties. So it's in a martensitic phase, it's bent. We dip it into hot water and it straightens up back to its austenitic phase. And also it's regenerative. So once it goes back into autoclave, it regains its original atomic state. And if you see any straightening of the spirals, then you know to discard them. I did a little comparison against instruments that are previously used to use, just to out of curiosity, to look at how much of shape memory, because the ProTaper Gold and the Wave One Gold have made a dramatic improvement in the metallurgy by making it a little bit more flexible. But when I look at the amount of martensitic property that the Hyflex EDM has, there's no comparison. There's still a lot of shape memory in the other instruments. So the benefits of the martensitic properties are that there's no transportation, we're able to pre-bend them, high cyclic fatigue resistance, and they are very flexible. So let's look at this case. This was a resorption. After looking at the CBCT, I found that it was an external resorption and it was supracrestal. So I decided in this case here, instead of doing a conservative access cavity, I'll do what we call an opportunistic access cavity and trimmed away a bit of the gingiva. And I decided to enter directly from the external resorption defect. And Hyflex allowed me to do that. I was able to pre-bend, access the canal, and clean out successfully. In cases like this, where we have a split, I mean, this premolar, the canals were very tiny, and they split at about the crestal level. I like to use the endo handle in this scenario, and this endo handle, if I could just show you the video, basically you attach your hand instrument to it, and what I like to do in this case here is locate the canal, access it, and to prepare the canal, I screw away I remove the endo handle so that the instrument is left in the canal only. And then I start to prepare my canal. And so I would do this for in this scenario 6, 8, 10. Got my glide path, and then I'm just going to show you one of the Hyflex instruments that I use there, pre-bend the tip, and I'm able to access. So in these cases here, it's a great benefit. Also in areas, patients that have very limited mouth opening, we're able to access canals that I couldn't before with files with a lot of shape memory in them. One word of advice here is to always keep whatever system you're using, keep your flutes clean. But this is the 2005 instrument, and I use the TCA technique, which Isaac is going to go through with you. So, and you see the debris collecting in certain flutes. And it's important to keep the flutes clean, because once the flutes become packed with debris, the file doesn't cut efficiently, and we get more torsional stress, and it can result in file fracture. And for me to do this efficiently, I keep some netted gauze on my tray all the time, and I flood it with sodium hypochlorite. So it's easy for me to just clean my flutes between the nets. And also, it's important to maintain patency. So that's just with a number 10 or a number 8 hand file. And you can just see in this example how it cleared up that area with packed debris so quickly. Some studies on the high flex EDM. This was a good study by Pirani. It studied various aspects of high flex EDM, the metallurgy, the cyclic fatigue resistance, and they did a comparison with the high flex CM as well. So in the metallographic analysis, what they found under the scanning electron microscope is that after high flex EDM was used in 10 severely curved canals, there were no fractures, no blunting, and that crater-like irregular surface was preserved perfectly. So what that tells me is that I can safely use it in 10 canals. I would say I would say I can do 12 comfortably. So about the 3 molars is perfect for me. After I have 3 stripes on the instrument, I'm ready to use it again. So if we look at a comparison between the high flex EDM and the high flex CM, we find that we have a serrated surface on the high flex EDM because of the electric discharge machining, and here's your milled surface of your high flex smooth milled surface of your CM. The fracture resistance of the high flex EDM, when it was compared to the CM, it was found to have 700% more cyclic fatigue resistance than the high flex EDM. And how it's calculated is with the number of cycles to fracture. So if we look at the 4004 high flex CM file, it was 257 cycles to fracture, and the 4004 EDM file was 2013 cycles before it fractured. When compared against the one shape, wave one gold and reciproc blue, the high flex EDM was significantly stronger than all these instruments. Again, in this study, it was compared. This was a good study. It was compared against ProTaper Universal and ProTaper Gold, again, high flex EDM was significantly stronger. The number of cycles to fracture was 3,689. ProTaper Universal was 350. That's expected. That it's old technology. And the ProTaper Gold, 915 cycles to fracture. Not bad, but not as good as the EDM result. In this one, it was compared. This compared the glide path file against the 1G and the Pro Glider. And again, EDM was significantly stronger than the other two. And the studies go on. I mean, here's a recent one. This is a recent one with high flex EDM. It was significantly stronger than reciproc blue, wave one gold, and TF adaptive came last in this study. This was a very recent one, November 2020, where it was compared against True Anatomy, VDW Rotate, R-Pilot. And in this study, actually, the R-Pilot file was found to be stronger than the high flex EDM. So it had more cyclic fatigue resistance. Then came high flex EDM, then VDW Rotate, and your True Anatomy was last on this list. So in all the studies, the reasons that the authors give are very consistent. The resistance to file fracture of the high flex EDM file is due to two properties: the martensitic property and the EDM surface. In this study, from this has got nothing to do with dentistry. This was from the International Journal of Fracture. So they measured what effect more martensitic properties will have on nickel titanium, and they found that the more when they increase the martensitic properties of nickel titanium, it created 47% increase in fracture toughness of nickel titanium. This is a case where I think the dentist didn't know where to stop here, because there were 3 instruments fractured between the MB1 and the MB2 canals, and I used ultrasonics to remove them. I wasn't using a loop technique or a lasso technique at that stage, and in the end there was only one canal. There was no MB1 or MB2. So I felt that the dentine removal may have been a little bit excessive. So I filled it with Pulfic bulk flow in this case. This is a case that I did using the max curve sequence, which Isaac will outline with you. Another max curve, and I'm just going to fly through it. There was a separated instrument which was bypassed, and I comfortably prepared it with the 2005 and obturated. It's got a perfect fitting 2005 GP cone that goes with it. This was with the HiFlex 1.5, and just to demonstrate the preservation of the canal anatomy on that MB canal. Another separated instrument that was successfully bypassed, and 2005, that was my limit. I don't go higher than 2005 when I bypass an instrument. And MB2, and even I mean, in some cases it's quite rare for me, but I also pick up the occasional DB2 as well. Some nice curvatures here. I just stopped on 2005. Severe case in the upper molar and on a premolar. And so to round up my presentation for you before I hand over to Dr. Isaac Sibui, I'd just like to leave you with, this is the HiFlex family. We have our orifice opener, 1503 and 1005 glide path 5, 2005 and 25 one file. And the new member of the family is the HiFlex remover. This is run at 400 to 800. Again, Dr. Sibui is going to speak in detail about it, but I just want to round off by showing you two cases that I did on a block. This instrument is not meant to be taken to length. It's meant to be taken to about 3 millimeters before length. And this was after obturating with the bioceramic sealer and GP, and I left it for 24 hours. And you see it removing that, it just, the friction just melts the GP and removes the mass of it. And then from here, I switch on to the HiFlex one file. And the advantage here is that I can pre-bend before that curvature and then just successfully get the GP out. And then I decided to give it a go also against one of my nemesis, and this is a thermofill option. One of my partners in the practice uses thermofill, so I asked him to obturate this block, and he obturated it with thermofill and AH plus. We left it overnight, and let's see what it can do against a thermofill carrier. Apologies, I didn't wait for the end of that video, so I just started again because there's something I want to show you in this video. I was a little bit naughty. I didn't follow the guidelines and stopped 3 millimeters short. I went to apex with it, which is not recommended, more because it can cause a lot of extrusion of debris. But I decided to just test it out in this case. Okay, I think it's frozen there. Okay, thank you very much for your attention, everybody. Don't go away, please stand by. I'm going to stop sharing my screen, and Isaac Sibui is going to take over the presentation now. Thanks a lot for your attention. And Isaac, the floor is yours, Isaac.
Thank you very much, and that was a very informative lecture. I enjoyed it, and I hope to just go through what you where you touched. And thanks to everyone for joining us this evening. I'm actually happy. I've learned a lot from Dr. Seedat's lecture. Well, I'll start off where he left off. I mean, the iFlex EDM family of endodontic files. As he has already highlighted, these are the files that we have in the HiFlex EDM family. As you can see, we've got an orifice opener, and we have the two glide path files, and we've got a 2005 and a one file, followed by those three files, which is 4004 and 5003, and the other one I think is 6002. Now, new in the family, as he has already explained, there is the HiFlex GP remover. Now, without any waste of time, ladies and gentlemen, Dr. Seedat has already mentioned that there are major goals for mechanical root canal preparation, and I just wish to touch on what he has already said. We need to remove the necrotic and vital tissue from the main canal. We need to create sufficient space for irrigation and medication. Now, another thing to consider is to preserve the integrity and location of the apical canal anatomy. And the other thing is we need to avoid the iatrogenic damage of the root canal system. We also need to facilitate the canal obturation, of course, and conserve sound root dentine. Now, it is actually not proper to talk about root canal preparation without, mentioning how we found these apices, and without talking about the apex and how it is and the anatomy of the apex, because we mostly talk about the apical constriction, and our lectures and the way we guide attendees. We're not stressing enough that some teeth has resorption, as apical resorption, such that you don't even have that apical constriction. And that is very important, ladies and gentlemen, because as you work, and even when you use your apex locator, you find that you can't, really locate them. Some, apices are so, conserved that you don't even have to to doubt if your last file that you used is actually the exact size of the apex. Now, just a quick guide. We're using rotary files. We're using the NiTi files, and you don't introduce any rotary instrument, whichever file system you're using, you never introduce any rotary instruments before a size 10 stainless steel hand file goes easily to length. That is, it must be super loose. And as soon as this size 10 stainless steel file is super loose, it means that you have actually expanded that canal a little bit bigger than a 1002, which is your size 10 stainless steel file. So once you have expanded it, that's where you can think about putting or introducing your rotary file. Now, rotary instruments must follow, not create a pathway for the canal. So what does it mean? It also supports the previous statement that you don't introduce any rotary file before your glide path is properly created or is properly prepared. So you always aim for a slow, constant enlargement of the canal. You started with a 1002, which is a stainless steel, and from there you have to go to a larger file. You'll remember that previously we had path files as the rotary glide path files. I think there was a 13, 16, and 19, if my memory serves me well. And now in HiFlex EDM, we've got a 15.0, and 1005. We'll talk about that later. Now, rotary files should have minimal contact with the root canal system. Dr. Seedat spoke of preparing a canal, about 10 canals. I remember very well when I started using the HiFlex EDM file, because we were given them to start, to test them. I actually did 16 canals with it. But key to that is that your glide path should be well prepared. Otherwise, you're only going to, put strain on the file. You actually overusing it. I'll put it that way. But if I want to be rough, I can say you abusing it because you actually turn that file into a drill. We're not drilling canals, but we're following canals and we're preparing canals. So you don't have to force instruments apically. You just have passive. You put the instrument into the canal and rotate it. I'll tell you how I do my preparations. There is no force involved in preparing your canals. Now, the rotary or reciprocating instruments that follow a designated route result in more successful outcomes with minimal mishaps. Like I said, if you force this instrument apically, you're going to fracture it. Dr. Seedat has mentioned about torsional stress. That is what is going to happen, and you separate your file. Many rotary files have non-cutting tips. What does it mean? It means that the tip of rotary files is actually guiding the cutting surface of the entire file into the canal. So even if you apply pressure, the tip is actually not cutting, but rather the fluids that follow. Now, what do we look for in an endodontic file? I just like to touch on a few points. We look for safety for the patient, safety for the tooth, safety for the clinician or the operator. Now we also need an instrument that is effective, instrument that is efficient, instrument that is flexible, and of course cost effective. I mean, if the price is higher, it means it should give me more canals. I should be able to reuse it. If the price is too high and I only use it once and check it out, it means I have to charge more from the patient. So cost, it's something that we need to consider. Now, the other thing is simplicity. Simplicity in terms of technique. I have to use fewer files and I should be able to do retreatment. Now, I must admit that this slide, I did it, I think it was 3 years ago, and there is retreatment in it. And Dr. Seedat spoke of a retreatment file, which is an addition to this family. I mean, there was no file that we used to retreat in the HiFlex EDM family. So now this slide was done, like I said, three years ago, but retreatment was there. So it means that was, the weakest link, in the HiFlex family. Now, Frank Wayne, in 1975, I was 2 years old, said, understanding the ramifications of the file and the technique design relative to the canal anatomy enables the dentist, let me say the clinician, to consistently achieve the most excellent treatment with less risk. That is, you cannot use this instrument without actually familiarizing yourself with the anatomy of the root canal system. Otherwise, you're just going to use them probably a carpenter is better because he knows he's working with a blank. But now we're working with dentine, we're working with a tooth that is, in humans. So we need to know the anatomy. Now, ladies and gentlemen, this slide, I like it, by Antonis Chaniotis. It explained the dimensions of the family of the HiFlex EM5. I've mentioned the orifice opener. As you can see there, it is a little bit bigger, and you can see that this is a file that is going, if you sink it into the canal orifice, you're actually going to leave that orifice at 133 millimeters. And that is too much. You will actually have removed what we said you shouldn't remove. You should preserve dentine. And one thing that I need to mention is that dentine is actually the most effective composite we are having. So if you remove it and replace it with any other composite, it doesn't match it. So we need to preserve the pericervicular dentine. So this instrument, the orifice opener, you don't sink the whole instrument into the orifice. Otherwise, you'll just, rather remove the tooth. That's where implantologists are going to say, look, endodontics is not working because, I mean, the tooth it's left weak, and then it remains brittle. We'll come to that later. Now, we've got here the 1503. I like this file, and when they introduced it, it actually made my life easy because I wasn't that happy with this glide path file, which is a 1005. Now, as you know, the stainless steel, a size 10, it's a 1002. What does it mean by these numbers? I actually this is my wish that everybody should make sure that they understand when they say 1002, they mean that at the tip, it's 10 millimeters. Now, for each and every millimeter towards the coronal aspect, it means it increases by 2%. So if it's 10 there, it means it will be 12 here. So then you increase by 2, it's 14 and all that. So your stainless steel actually is, 42 at D16. D16, what we mean by that is that files are manufactured. There's an ISO, the working surface of the file is actually 16 millimeters. So at D16, that's at the 16 millimeters, the stainless steel 1002 is 42. Now let's go to a 1503. It means it should increase by 3. For each and every millimeter, it should increase by 3. As you can see, from 15 it goes to 18. Let's go to the D16. It's at 62. You can see that already you have increased your orifice. I don't want to confuse you with all this, but I just want you to grab this this concept. And we're moving on to the 1005. I have said earlier on that the taper is so much that it increases too much. From 10, it goes 5, it's already at 15. And look at the size 15, where it is. Now, the stainless steel went from 10 to 12. And this iFlex EDM glide path file went from 10 to 15. And look at the D16, it's already at 90. Now, you ask yourself, the use of this orifice opener, if you have a file like that, the use of this orifice opener, if you've got this 1503, that will give you a 62. If I have to be so much conservative of the pericervicular dentine, I would rather use this file, limitedly so. So now we've got a 2005. Ladies and gentlemen, I must tell you, I must be honest with you. Most of my root canals, I use up to this file. Because to me, I think I preserve more dentine with this file. And as I've mentioned earlier on, that we're creating space to introduce our chemicals, sodium hypochlorite, into the root canal system. So with a 2005, I'm satisfied. I know there's the palatal canals where we use the one file. Of course, this is a 2508. It is 08 only up till 5 millimeters. From there, it's a 4% taper. The reason that is done is so that if you go a constant taper from, let's say, 8%, like I said, and it's a constant taper, at D16, you will actually have prepared a class 1 amalgam preparation on this tooth. Of course, we've got this file, which is a 4004, followed by this, which is a 5003, and of course, we've got a 6002. So you will understand as we go on why this is like that. And this yellow part, I think most of you will want to understand what does it mean. I've mentioned that the file should actually, at a given point in time, this file should only be working on the root canal system with a small area. So we don't want binding of the file to that root canal space. You can see this glide path file. Actually, the tip is guiding because already you've got a glide path of your stainless steel. So it's just guiding. It's only the middle third of this file that is working. I think I've spent more time on this slide. Let's go on. Now, Sleiman in 2005 said the greater the tapered preparation, the greater the quantity and the concentration of the irrigation solution, and greater the elimination of the microorganisms and the smear layer. That was that. All we need to know is that we create a path in the canal so that we can have a solution. What we have to do is constant renewal of that sodium hypochlorite. And as we do that, it means we're increasing the volume of the sodium hypochlorite into that canal. As much as we increase the volume, it means small preparations or conservative preparations or limited dentin removal can result in the same manner where the microorganisms are reduced to minimal within that root canal system. Now, studies have shown that in large canals, it's not a matter of increasing the diameter of the foramen, but conicity. 6 to 8% taper for irrigation. That was it, and this was by Laslami et al., who also say that apical disruption violates the principle to maintain the apical foramen in its original position. What does it mean? We don't have to cause iatrogenic problems there. So you leave the apex at its original position. You don't transport it. You don't, increase its size. That will actually lead to the quicker healing of the periapical tissues. Now, instruments with apical size similar to the diameter of apical constriction yielded the best result. This is by Birada et al. Now, still supporting Laslami et al. Study. So it means the apical constriction is actually of utmost importance. It's an anatomical landmark that we should make sure that we preserve it. Now, achieve complete canal conformation with the least number of file possible. That is by Didier Serra. Now, I've already mentioned that the efficiency and the use of less files as we work, it's what we strive for. Hence the introduction of one file system. We used to have the crown down technique, step back technique, and all that, and the hybrid technique. But we've got one files, we've got rotary files that you can go, with a hybrid or a crown down technique and quickly prepare the canals. Now, Dr. Seedat mentioned also about the control memory. This is actually that tooth over there with 90 degrees, bend there. But how the file works, this is a 2005. It's actually a an X-ray image on the computer screen. So I just bent it to follow the root canal, and it is not straightening because of control memory. And this is flexible. So what does it mean? It means a file that has these characteristics can actually enable a clinician to have conservative access cavity preparation as well. Okay, now about flexibility. I've got 3 files here. This this is an experiment that I did 2 weeks ago, and Dr. Seedat, I keep on going back to him because he spoke of keeping the file central to the root canal system. This, ladies and gentlemen, it's a Chinese file. There's something that I've ordered online, and they said I must test this file. I forgot even the name because it's written in Chinese there. So, but look at what is happening. This file is true anatomy. It stayed central to this root canal system. I think this is all these blocks are the ones that we're using for training, you know, to just for maximum curvature and all that. But look at how it remains central in the canal. And this is, by the way, this is 2004, the true anatomy. And this is 2005 high flex EDM file. Look at how centrally it is located within the root canal without transportation. Now, this is the Chinese file, like I've already mentioned. I don't even know the name, but you can see that it's actually how can I put tilted to one direction. It means this file is trying to straighten up, and as it tries to straighten up, look at the curvature. This has transported the canal. We didn't leave this canal in its natural form. So this is what happens when you use files that are so rigid and without control memory. Now, let's look at this video. I'm just concerned because I saw when the videos are playing on the other side, they are so slow. Let's hope that this is going to be quicker. This is a packing motion, and I just want you to look at what happens at that curvature. It is actually grinding away the outer surface of this block, and that is actually transportation. You're actually straightening this canal. So look, when this has finished preparing, and by the way, that is ProTaper Universal that I'm using here. So let's look at this following video as well. This one I'm using, I've already prepared the glide path. This is a 2005 high flex EDM, and I'm going to be using packing motion. And look at the speed of the preparation, because the file is so efficient. I'm already at the apex, and the file has actually followed the natural occurrence of the canal. Now, techniques that we use with this file, Dr. Seedat has already mentioned about that. Packing and TCA. TCA means tactile control activation. We'll go into that. And then all high flex EDM files except the 1005 and the 1503. All of them, you can use them with the torque of 2.5 and the speed of 400 to 500, as Dr. Seedat has mentioned. So with me, even the 1503, I know the manufacturer said 1.8 Newton centimeters and 300 RPMs. I used 2.5 and 400 RPMs. I get better results. But the key is in your glide path. If you can prepare your glide path nicely, then as you can see on the video there, already you are at working length. So the glide path is actually reproducible. You can actually introduce your rotary files here. I mean, I was using a very small file there, and from there I moved in with a 20. I didn't create on that MD2. That is a packing motion. And I just want you to see that you don't have my solution in the canal being pushed apically. Actually, all the debris is being gauged outwards. And that's what we like in a file. we don't want all this debris to go apically. Then you just that is quick. After that, you simple um, irrigate there, and then with just few passes, you already prepared your root canal system. Now, the high flex EDM maximum curve. These are all files that I use for maximum curve for all those dilacerations. I put a stainless steel file here. By the way, you know that you can go to 802, and you can even go back as far as 602. But these are the files that I use for maximum curve preparations. Now, the difference it's in this manner. In the maximum curve, once you have your glide path prepared with a stainless steel 1002, you go to a 1503 to working length. Now, when you go to working length, you can see the size as it increases up till D16. So this file is actually a D16 smaller than your glide path file, which is a 1005. Now, from this file, you go back to a 1005. Tell you what, I've already mentioned it. The 1005 is not going to prepare your apical third, but it's rather going to prepare your middle third. I've mentioned before that we should always make sure that we prepare the canal in stages. We want minimal file engagement with the rest of the canal. So this actually makes sure that you negotiate the curvature, the rapid bend effectively, because of the fact that the tip is only acting as a guide, and the middle third of this file is the one that is working. That is why you can actually make sure that you use these files in as many canals as possible because of the minimal engagement. Now, with the sorry about that, I need to go back. Yeah, with the 2005, you will have realized that many studies have said that the maximum curvature you need a 2004. We've got a 2004 in high flex CM, but now we have a 2005. I've done maximum curvatures with this. I think I've got maybe one case that I'll like to show. Now, we've got the TCA technique, like I've mentioned. Watch this video, how Dr. Antonius Chanotis is working on this premolar. And firstly, you make sure that you introduce your stainless steel file. And by the way, I like stainless steel files because once you put them in the canal, they will actually come out giving you information. I don't have a CBCT so far, and I pray that one day God bless me with one CBCT, and I'll be happy because there's a lot that we need to do in endodontics, and CBCT gives you a lot of information. I find myself, traveling so much, and sometimes it's unnecessary to do that while you're looking for MB2. And if you have a CBCT, you would have seen that that is not there. But unfortunately, we have to go the guesswork. But as you can see, he is negotiating the canal. He's making sure that there is a nice glide path there. He's doing a watch winding, and from there, what he's going to do is now he goes in there. He's actually feeling if this file is getting resistance. If there is no resistance, it means the glide path is reproducible. Then he can actually go and use a rotary file in there. Now the next rotary file that needs to be used there is a 1503. And now, as you can see, this one it's a high flex. It's a high flex CM that he's using. You can see even the flute. He's introducing it in there. just to expand, the glide path. And now he's introducing high flex, and that is up to working length. Then what I need to explain this. What TCA means is that you introduce the file into the canal. That is a 1503 that is introducing now, and look, it's binding. Then you activate just a little bit, take it out, wipe the fluids, irrigate, go back in there, and then you will advance a little bit apically as you activate. Just a little bit, it goes up, out. He doesn't keep this file running within the canal, because if you do that while it's binding, you're actually going to have the lock there, and you separate the file. So what he does is just activating the motor, and take it out, irrigate, go back in there until he is at working length. I'm not going to spend much time on that. These are my clinical cases. This is one of the cases that sometimes you get forced to work on wisdom teeth, those curvatures. And the difficulties about this thing is that patients cannot open their mouth as wide as you would like them to. So iFlex EDM is actually so good that as you bend it, I can locate the orifice while the file it's bent. So it was easy for me to go for a tooth like this. In an actual fact, I'm not even scared of any tooth now. Just 2 weeks ago, a patient was afraid to extract a 4/8 which was impacted, and she said, "No, do something about it." I did a root canal. Unfortunately, it's not in in this presentation, but the difficulty is negotiating those curves. But with these files that are so flexible, it's easy for me to do that. And this particular one came out so nice, and I used bio sealer, and that's how it came. That's how it finished. I mean, this is a nice one. If you say that this is not a maximum curve, then I don't know what the maximum curve is. Okay, now here is another case. You can see I bought a new sensor. This patient came from another dentist, and I don't know what happened there because there's a filling. Now, I went in there, there's an MB2, and of course, your cone fit. After that, that is what is it's important. And this is the finished case. You can see there's an MB2. I've got an extrusion of bio-sealer. Because it's a bioceramic cement, I'm not even shaken about that thing, because it's osteo-inductive as well as osteoconductive. So there's going to be bone formation around this. The only time where you get a little bit worried is if it gets into the maxillary sinus, and you start getting worried about it. This is a finished case. I'm happy about that. And in most cases, I try by all means to be conservative with the access cavity. Here's another case. Actually, this is the case I did today, 4 p.m. I just included it here. This is my preliminary working length. And in fact, this was a surprise, because I thought I've got all the canals, 3 of them, because the distal was 1 and 2 mesials. But as I used the microscope, I saw that in an actual fact, I was working on a mid-mesial. There it is. So this I did it today. Of course, that is the bio-sealer, and I finished it. You can see the buccal, actually the mid-mesial and the buccal, they just meshed midway there. This is another case that I did, and I used bioceramic sealer. You can see there, I don't have an explanation, but that looks like a ring there. So we put a ring on it. But what I want to demonstrate on this one is that your responsibility as a clinician is to make sure that you maintain the vitality of the pulp. Now, I have two scenarios here. That tooth, non-reversible, irreversible pulpitis. This one here, our pulp sensibility was positive, and this tooth was fine. Even when I went in there, I found that there is actually tertiary dentine formed there. I didn't go in there. I didn't expose the pulp. So I maintained the vitality of that tooth. I actually worked on the 5. And the result was actually very good. And the patient is happy with that. Now, here is another 3.8 that I worked on. I think some of you might have seen this case. The patient didn't want to take it out, and I'm actually busy because I'm just a general dentist, but mostly my interest is on endodontics. So I've already put braces, and this tooth is moving mesially. It's actually being uprighted as we speak. Now I've excuse me. Okay, I need to show. There. I spoke of your stainless steel. When you introduce them into the canal, they come with information. Even if you don't have a CBCT, this tells a story that where you're going, you should start considering increasing or expanding the canals intermittently. As you can see, that is the case. I managed to, negotiate my way through. This is the case that I think I presented this last only 2 weeks back during our Omeri Virtual Congress. This is a tooth that surprised me, but I still lack somewhere, because you can see I removed the amalgam there. But the first thing is diagnosis. Look at the distal, it's actually wider than the mesial. This should tell a story that something is not, it's not normal. So if you're going to follow the Kranzner and Rankov, canal location, laws of symmetry and laws of, you should start thinking differently when you see something like this. And this, what happened here, as you can see, those were my files at working length, and the GP cone fit there, and that is the finished case. Now, you prepared your canals. You did the TCA, the canal is ready. But what is it that you need to know after that? Because the last file that you use in that canal, you should actually put the GP that is exactly the size of that canal. Ladies and gentlemen, I made sure that I put an old file here. I just wanted to show something. Can you see that you lost the roughness of the file already? It's shiny. This has seen it all. Look at the tip. It's shiny. If I see something like this, I consider putting the file away. I'll use it for my phantom work. So now, with this, I want to demonstrate something. This cone here, this GP, it's a 2004. It's a 25, sorry, it's red. It's a 2504. And this one here, it's a 2506 GP. And this file here, it's a 2508. Now, with HiFlex, we don't have a GP that exactly matches this file to be a 2508. Reason being that it's a 2508, but the 08 only goes 5 millimeters from the tip. 5 millimeters from the tip. 5 millimeters from the tip up till 5 millimeters. Let me put it that way. Now, what does it mean? This is a constant taper. And as you look at it, it looks bigger than the actual file. But what does it mean by the taper? Look at this. This is a 25 at the tip, and this file is a 25 at the tip, but this looks smaller. That looks bigger. So if you're going to do your cone fit, you're more likely to get a false tuck back into your canal, because this is going to get stuck at the orifice if you're not careful. But now, what made high flex EDM or Coltin think about this, the 2506, is that most canals, most root canals from the orifice up till the tip, it's around 16. If it's around 16 millimeters. If it's more, then it's 17, around 17 millimeters. I saw a study that actually validated that. But now, if you look at the high flex one file, say you use the 25, up to 10 millimeters, this is exactly the same measurement. So you don't have to panic. You can use this effectively. So those that had questions about it, there is your answer. At 10 millimeters, they are the same. If you think you are getting a false or a false tuck back, check your cone at the tip. Sometimes you can see that the tip doesn't want to go through the apex. So you find that it's bent a little bit. Know that you went up till the working length, so there is no problem there. If it happens that it's a false tuck back, then you can use your orifice opener a little bit, or just brush south, east, west just once, and you will have expanded the orifice. Now, if should Coltin has made a 2508 without taper, look at how big or how wide at G16 it would be. This was not going to fit into the canal that is prepared by that file. Now, ladies and gentlemen, what are the histological features of healing? According to the study there, if you stop your procedures at the apical constriction and succeed in control of infection in both necrotic and vital cases, in addition to normal radiographic appearance of the periapical tissue, regenerations of normal trabecular bone occurs histologically together with uninflamed, periodontal ligament, and vital uninflamed fibrous tissue in the apical portion of the canal. Calcification with cementum narrowing of the canal circumference may sometimes occur. So endodontics works, ladies and gentlemen, if you actually follow the protocol. Now, despite all this, despite the nice obturation, nice preparation, and making sure that everything works nicely, we still have to do retreatments. It happens. Sometimes there's missed canals. Sometimes it's because you have to do a crown and you realize that you're short of the apex and all that. So that is why Coltin has decided to come with a retreatment file. Dr. Seedat has introduced it. And why retreatment? I've already mentioned failure of the initial root canal treatment, new problem, that is decay, continued. Sometimes when we do our access cavity, we leave caries there because, we're in a hurry to go into the canal. But, sometimes it's just technical. Now, causes of initial root canal failure, improper treatment strategy. Sometimes incorrect oral examination, missed canals. I don't have a CBCT. I've already mentioned, some retreatments because of iatrogenic errors. Now, why a new file? The introduction of a new file is there was no file, like I've mentioned in my initial talk, that there's no file dedicated to the retreatment yet, but now there it is. And the other thing is just to have a competitive advantage, it's competition. The other reason is that we need a one file that can do retreatments. Remember, we have to use solutions to soften the GP and all that. Some patients are very sensitive to such. So With this file, we don't have to use a solution. We just go in there, it cuts the GP. Dr. Seedat has already spoken about the thermal field. It removes it so quickly. Now, what are the characteristics of this file? It's heat treated, 1 millimeter wire. It is the actual wire, but the fluids make it bigger, looks bigger. Triple helix with open fluid. I don't know if I should go through all this, but now the debris are removed coronally. You will see, because I've got a video that I have now for you, and it respect anatomy. It is very flexible. It's the EDM, family, meaning it's flexible. So as compared to the orifice opener, this file is actually a size 3007 taper. Now I've done my calculations there at D16. I can't remember how long this file is actually, but if it's up to 16 millimeters, the working surface, at D16 it should be around 135. You can see that it's actually bigger than our one file already. All that I know with retreatments, there's no way you're going to increase the size of the canal. Now, compared to our orifice opener, it's at 133 at orifice opener, I think it's 9 millimeters, if my memory serves me well. Yeah, it's 133. Dr. Seedat, am I right there?
It's 15 millimeters.
Yeah, 15 millimeters. Okay. Now, so the 3007, it's a 7% taper. As you see these calculations, 30 at the tip, 1 millimeter is already at 37. Now, the motor settings when you use this file, remember, I haven't told you about the high flex EDM. All high flex EDM files is continuous rotation. Right? I know there are some clinicians that are using them with reciprocation. I haven't tried it, and I'm not sure if I want to try it. Now, this specific file, because it's GP removal, continuous rotation, you use 400 to 800 RPMs and 2.5 toe. Now, just something, Tanya, I think you will have to correct me if I'm wrong here. There is a misprint in that package, because they are speaking of the toe of 3. I'm not sure if that has been corrected. If it hasn't, then this is how it should be used. 2.5 Newton centimeters. That is the toe. It is a single use. One patient, I don't do that. I use it often. I use it quite a lot. But anyway, I have to be careful with that, because if it breaks, then Colcane has nothing to do with it. Now, here is an example. Ladies and gentlemen, I work on extracted tooth before I go into the patient's mouth. This particular tooth, I did it on the 8th of September 2019. And now when I received this file, there I cleaned, and that is when I've removed the GP. And another thing that I didn't mention, you actually have to remove, to go into the canal 3 millimeters short of the working length. You don't have to go all the way to the working length with this file. I'll talk about it. And as you can see at the distal, this was not actually, tapered, smoothly tapered. There's a little bit of a bulge there. That is why you see a GP has been left there. And after this, you need another file to remove that. And that's when I'm using a different file system. I use an XP Endo finishing file. It removes that effectively. Now, this is after removing. That is the video there. I make a dent with an orifice opener. Then I run this file at 600. There it goes. You can see it chips this that distal canal obturation. It just go quickly. I mean, I'm not spending much time on this. Already, I've reduced up to 3 millimeters short of the apex. That's how easy it is to use this. No solutions, no solvents used. The picture here, it shows that all the GP is actually chipped into the uh, 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 into the access cavity. Now, here's a case. I was working on an anterior. Let's see how I used it. Exactly the same way. 3 millimeters short of the apex. That is quick actually. This just goes straight. You can see the chips coming out of the cavity. And just to show you, 3 millimeters short, and there's little remnants. I used high flex EDM to remove the rest, and it is clean there. That is my bioceramic sealer, BioC sealer. Then this is the finished case. Now, before I go to that last but one slide. Once you have prepared once you have removed the GP, you can use any file system of your choice to remove the remainder of the 3 millimeters. Hence, I'm saying the little piece of GP that is there, I use XP Endo. I found it working effectively in these cases. Now, clinical considerations and take-home messages. This is the last but one slide. Make sure that you assess the canal anatomy, familiarize yourself with the anatomy, use magnification and proper illumination. Rubber dam has already been mentioned many a times. Crown down, I've mentioned that hybrid sometimes works as well. Create a reproducible glide path. Always check patency of the canal and use files 5 to 10 seconds only. I don't, in fact, my root canal preparations, I spend less time during preparation. More time I spend when I'm irrigating. Now, you have to do adequate irrigation. Do not force files apically, I repeat, no force on the files. Examine the file before, during, and after use. Why should you do this? Is because if you examine it before, did you use the file before or not? Now, during, it's as you work on in the canal, the file, sometimes has shiny spots, or sometimes it unwinds because you've been forcing it apically. You must check it. If you find it unwinding, take it out because you're going to lose your working length. So after use, check it. Am I still going to use it, or I put it in an autoclave? Now, always wipe the fluids before reintroducing the file into the canal orifice. I had Dr. Seedat is cleaning with a cotton wool with soaked in sodium hypochlorite. I always have alcohol swabs next to me. Once I take it out of the canal, I clean it with an alcohol swab. Now, Omeri is used to this last statement that says, do not stay in the canal for long. That is why we say we kiss and fly. Once you are at a working length with rotary instrument, whichever file system you are using, do not go in there and cause an injury to the apical tissues because you need healing there. With that, ladies and gentlemen, I thank you. Back to, I'll just stop the screen sharing.
Thank you very, very, very much for that very informative lecture. I just want to apologize to the delegates for not properly introducing our two endo gurus of the evening. So I'm going to take this opportunity to just say a little bit about them so you know a little bit more about them. So Dr. Seedat, if you don't know him, he's a very well-known endodontist practicing in Umhlanga, KwaZulu-Natal, and he's been doing or in practice for more than 20 years. And then Dr. Sibuyi also runs a very successful multidisciplinary practice in Hazyview, Mpumalanga, and he has recently completed his endodontic diploma. Dr. Sibuyi is also in the industry for more than 20 years. So last night when we were practicing on the platform, they were very worried about giving away their age because the two of them together have more than 40 years of experience, clinical experience. And we could see that tonight with all the the whys and the advice and the clinical tips that you shared with the delegates. So thank you so, so much for that. This was a great collaboration from the two of you. I also want to just mention, Doctor, if you haven't followed all Dr. Seedat's webinars so far, this is his third webinar, and he has done irrigation, obturation, and now a safe mechanical preparation of the endodontic space. And if you have missed all of those aspects or key aspects in the endodontic treatment that you would need for a successful endodontic treatment, the links are on YouTube, and if you don't find them or you request the links, we can just send them on to you, and your local Milner's representative can also share the links with you. I want to go to the question and answer sessions. If there's any questions, please can you load them for Dr. Seedat and Dr. Sibuyi? Okay, while we wait for the questions, I'm quickly going to share just 2 minutes, some promotions for the evening. Okay, so in the HiFlex EDM system that was very thoroughly discussed tonight, we've got the shaping set, the medium shaping set. You can get the files individually in a pack of 3, and they're all on promotion for 689 Rand and 99 cents. If I refer back to Dr. Seedat's lecture where he said he does at least 12 canals with 1 file, you're looking at a minimum, according to literature, 10 canals per pack, and then not per pack, 30 canals per pack minimum and 36 maximum per pack. So if you divide that by the cost, you're looking at about 22 Rand, 23 Rand per canal per treatment. So it is a really cost-effective treatment, and you're getting high-end quality product. Then on the HiFlex remover, there's 2 lengths, Dr. Sibuyi. One is a 19 mil and one is a 23 mil. The 19 mil seems to be the more popular HiFlex option. They are 1,285 Rand, and there's 5 files in a pack. And then Dr. Seedat also mentioned the Venta handle. The handle is on promotion for 950 Rand. You'll probably buy one and it will last you forever. They have their own microfiles where they are pre-bent. So you can also use a normal K file and you can bend it with a bird beak plier. The only problem there is, or the only situation there is, you don't get the length because you bend it where the cutting surface starts. So the microfiles, you get them in H files, K files, and then the C plus or the calci files.
Tanya, I can see a question from Dr. Makanji about the speed.
Okay.
So he finds 400 RPM a bit too fast, and he feels like it pulls him deeper into the canal. The files are not meant to be used less than 400 RPM, and I don't think that it should be, as Isaac pointed out, forced into the canal. You must remember with these instruments, basically, if you go less than 400 with this, you're gonna experience a lot of torsional stress on the file. So the key, like Isaac has said, is to create a good glide path. And just allow the instrument to follow the canal. As soon as you meet that resistance, stop and withdraw, and then irrigate, recapitulate, put the instrument in with the motor switched off, and you'll find it would have gone a little further and activate again at that point until you meet resistance again. But I think that it is risky to use it at less than 400. I use them at 500 RPM, and I'm quite comfortable with that speed at present. But I think just try the proper TCA technique. What would your comment be on 400 RPM being too fast, Isaac?
I use 400 RPMs and sometimes move to 500 RPMs. The key to that is that, all files, the lower the torque, the higher the speed the file should be used. If the torque is 1.8, they use higher speed. That is the preparatory files, not the glide path files. I can give an example. I think XP Endo, it uses up to 100 RPMs, but the torque is something.
1,000.
Yeah, 1,000 RPMs. And the speed is, the torque is 1.5. So it is the speed that works. So now the high flex EDM is 2.5, and the speed is 400 and 400 to 500. So you can control it. In an actual fact, what I've seen with the file drawing you into the canal, it's when you actually start running your file outside the canal. Put the file in the canal, meet resistance, because it's of no use if you run your motor while there is no resistance. Put the file in there, meet resistance, and run your file. So you actually give it energy because it meets resistance. You don't just give it energy while it's just wobbly inside the canal. That also will help you to know that the last file you used is actually the exact size of the apex at your working length. Sometimes I just put a 2005, it goes to working length without running a motor. Then what I have to do is, just irrigate and spend much time on irrigation or increase the file size. Thank you.
Okay, I don't see any other questions. Okay, I think everyone's also tired, long day, but thank you very much again, Dr. Seedat, Dr. Sibuyi. Thanks for your time. I know all the preparation that goes into a webinar like this. We really, really appreciate it, and we can always learn from you guys. Thank you very much. Thanks to the delegates. Have a good evening. Almost weekend, almost there. Good night.
Yeah, good night.
Thanks. Bye-bye, guys.
Bye.